Hello, I'm Matthew Murrah,
I'm Grant Erickson.
and here is our final project for kinesiology. We decided to do our project on a snowboard 360. So, with this movement, what happens in terms of the body is three main things, looking at your ankle, your knee, and your hip joint. As you can see, as the snowboarder approaches the jump, they bend down, flexing their knees, flexing their hips a little bit as well. As they get closer, they begin to use their core to turn, and as they reach the top of the jump, they push off from their foot through their knees and extend, through their hips, extend as well, and complete the turn, spinning as they go over the jump before flexing their knees again as they land to cushion their landing. So, looking at some of the major bones involved in this motion, we're going to start with the ankle. Obviously, as you're pushing off of the foot, pretty much all of the bones of the ankle are going to be involved. But the most noticeable ones are the calcaneus, the talus, and the metatarsal bones, as they're the primary points where they get pushed off of. Looking at the other side of the ankle joint as well, the tibia and the fibula are also very notable because they are the attachment points right there. And the main bony landmarks here are the medial and lateral malleolus, looking at the lateral and medial edge of the tibia and fibula. Moving upward a little bit to the knee, the main bones involved in the knee joint for this motion are the tibia, the fibula, the femur, and the patella. With the tibia, as you can see on some of these diagrams, the main bony landmarks are the tibia plateau, which goes between the tibia and the femur, the tibiocondyles along the edges of the tibia, the tibial tuberosity at the front, which is an attachment point for a lot of muscles, Gerdy's tubercle along slightly off to the side of the front of the tibia, and the pes anserine. The fibula, notable bony landmarks are the fibular head, that's pretty much it, just alongside the edge of the tibia. And with the femur, the main bony landmarks are the femoral epicondyles along the edges, the femoral condyles along the back, and the linea aspera along the shaft of the femur. Finally, the last little part of the knee that's involved in this is the patella, which is the sesamoid bone in the front of the knee. Then, looking at our last section of bones, specifically in bony landmarks, we move up to the hip, which is made up of the ischium, the ilium, the pubis, the sacrum, and the femur, all of which are partially involved in this movement. With the ilium, we have the anterior superior iliac spine, the iliac crest, the posterior superior iliac spine, and both the anterior and posterior inferior iliac spine. The ischium has the main landmarks of the ischial tuberosity and the ischial spine, and the pubis has the obturator foramen, while also including the sacrum, which joins the two iliums together, and the femur, which fits into the acetabulum to connect the leg itself to the hip, and the two main parts of the femur that we are concerned with, other than the head of the femur, are the greater and lesser trochanter, which are main muscle attachment sites.
All right, so for the muscles that we use within snowboarding, in this sport, there is exceedingly less movement within the ankle than there is in other sports. However, we do have a lot of action within the calf. So the main things we use are the gastrocnemius and the soleus in their foot plantar flexion, which allows for both the landing portion to correctly land your jump, or as well as taking off with your jump. You need the plantar flexion to get off the ground. And for the gastrocnemius, we come from the lateral condyle, the femur, as well as the medial femoral condyle, and then we insert onto the posterior calcaneus. Soleus, we come from the soleal line and the head of the fibula, and we insert onto the posterior calcaneus. Then we also have the tibialis anterior, because you have to have some sort of dorsiflexion if you're trying to land correctly, and then it's going to be an agonist to the plantar flexion that we see within the gastrocnemius and soleus. And this originates from the lateral tibia and then inserts onto the medial cuneiform bone, as well as the base of the first metatarsal bone. And then there's a lot more action that we see in the knee that we don't see in the ankle. And one of the main things that we see here is knee extension for balance, as well as knee flexion. So for knee extension, we have the vastus lateralis, the vastus intermedius, the vastus medialis, and the rectus femoris, all of the quadriceps. For the vastus lateralis, It originates from the greater trochanter and inserts onto the tibial tuberosity and patella. For the vastus intermedius, it originates from the um, anterior femoral shaft and inserts onto the tibial tuberosity and patella. And for the rest of the quadriceps, they do insert onto the tibial tuberosity and patella. So the vastus medialis originates from the proximal femoral shaft, and the rectus femoris originates from the inferior iliac spine. Now we also have knee flexion, which I stated before, and this comes from the hamstrings. And the semimembranosus, semitendinosus, and biceps femoris, all doing this knee flexion. They all come from the ischial tuberosity, and the biceps femoris also originates from the linea aspera of the femur, and the semimembranosus inserts onto the medial condyle of the tibia. The semitendinosus inserts onto the distal medial condyle of the tibia, and the biceps femoris inserts onto the head of the fibula. And then we also have some knee stabilization from the popliteus to make sure that we are correctly landing our stunts and not throwing out our knee joint. So this is, again, from the popliteus, and it originates from the lateral condyle of the femur and inserts onto the proximal tibia. And then finally, we have our major muscles within the hip. This is where we have much of the rotation that we see within a jump. So we have internal rotators and external rotators. The internal rotators we have are the biceps femoris, the sartorius, gluteus medius, and gluteus minimus. The biceps femoris originates at the ischial tuberosity and linea aspera of the femur and inserts onto the head of the fibula. The sartorius originates from the anterior superior iliac spine and inserts onto the distal, just distally to the tibial medial condyle. The gluteus medius originates from the gluteal surface of the ilium and then inserts onto the lateral greater trochanter of the femur, whereas the gluteus minimus also originates from the gluteal surface of the ilium, but inserts on the medial aspect of the greater trochanter of the femur. Then we have our thigh external rotators, which are the piriformis, the superior gemellus, inferior gemellus, and quadratus femoris, as well as the gluteus maximus to a lesser extent. The piriformis originates from the anterior sacrum and inserts on the greater trochanter of the femur, as well as does the gemelli. The superior gemellus originates from the ischial spine, and the inferior gemellus originates from the ischial tuberosity. Quadratus femoris originates from the ischial tuberosity as well. However, it inserts at the intertrochanteric crest of the femur, and the gluteus maximus originates from the gluteal surface of the ilium and inserts onto the iliotibial tract and the greater tuberosity of the femur. And it does have some thigh extension to help with balance while you're landing your jump.
All right, so now we just want to touch on some of the major ligaments and tendons that are involved in this action, starting again with the ankle. And looking at the lateral ankle, we have the anterior talofibular ligament, which combines the talus and the fibula, obviously. On the anterior side of the foot, we have the calcaneofibular ligament, which connects between the calcaneus and the fibula, and the posterior talofibular ligament, obviously back to the talus and the fibula, but on the posterior side of the foot. We also, on the medial side, have the deltoid ligament, which is a combination of ligaments that work together to stabilize the medial side of the ankle. In terms of tendons with the foot, we have your Achilles tendon, which takes the calf muscles and connects them to the foot. And we also have the plantar fascia, which is along the bottom of your foot and provides stability and support there as well. Moving to the knee, we have some of the more well-known ligaments of the body with the ACL and the PCL, anterior and posterior cruciate ligaments, which stabilize the internal part of the knee, preventing forward or backward motion. We also have the medial and lateral collateral ligaments, which stabilize the outsides of the knee and prevent side-to-side motion, whether it be medially or laterally. We also have two tendons in the knee, we look at the quadriceps and patellar tendon. Both of them attached to the patella at one point and extend out just providing knee stabilization and attaching the muscles, allowing for greater movement within the knee. And finally, in terms of ligaments and tendons, looking at the hip, some of the main ones we look at are the iliofemoral ligament, obviously attaching the ilium and the femur, the pubofemoral ligament, attaching the pubis and the femur, and the ischiofemoral ligament, attaching the ischium and the femur, all kind of working together to create that socket around the head of the femur, holding it in place. In terms of tendons, we have one big one is the iliopsoas tendon, which just makes sure that the iliopsoas is attached to the femur as well. But also the tendons of the biceps femoris, semimembranosus, and semitendinosus all work together to ensure that the hamstrings are attached properly and work to the best of their ability within the body.
All right, so I briefly touched on this before with the muscles, but we have the overall different mechanics that the different movements of the muscles do. So within the ankle, we have the main movement, which is jumping off a ramp. And this involves plantar flexion, which comes from the gastrocnemius and the soleus, as the agonist, and then for the antagonist has the tibialis anterior. But then for landing, we also have plantar flexion and dorsiflexion, where both switch back and forth between agonist and antagonist, depending on how you need to position the board. For the knee section, we do have the bending of the knees, which you obviously need to have when you are trying to lift off. So we have knee flexion, knee extension, and knee stabilization. So for the knee extension, we have agonists of the vastus lateralis, vastus intermedialis, vastus medialis, and rectus femoris. And then for knee flexion, we have semimembranosus, semitendinosus, biceps femoris. They go back and forth between how you want to bend your knee for agonist and antagonist. And then we have the knee stabilization, just the main agonist is the popliteus. And then for balance, you also need to position your knees once again to make sure that you're staying correctly up on your board. And then it's all the same different muscles, just depending upon how you want to lean forward or lean back and how deeply you want to position your legs. However, for the most part, knee flexors are going to be the agonist and knee extensors are going to be antagonists for this motion. And then finally for the hip, this is where we get the main form of torque and rotation in the movement aside from the core. And obviously we're going to have some balance as we're moving within the head. And this comes from the thigh extensors that we see within the gluteus maximus. Just a little stabilization there for everything else that we see within the knees. And then for the lower body rotation, we have thigh extensors and external rotators and thigh internal rotators. And this really depends on if you're going to be doing a 360 to the right or 360 to the left. So you could have the thigh internal rotators of your right leg the agonist for this motion, and the thigh external rotators of your left leg be the agonists, while the opposite holds true if you're going to be moving the other way. So it just depends on if you're going to be a righty or lefty for this movement.
For most of these other things, I'm going to use the actual body to explain them, but for the ankle joints and bones, it's a little awkward to kind of lift a foot up. So I'm just going to use this model right here. There's a lot in the ankle, so we're just going to start working through it. Primarily, we have the talocrural joint, which is the joint between the talus and the distal arch of the tibia. That's located right here, and that can be palpated by sliding down the tibia until you reach the talus and just noticing the joint in between them. Moving on, we also have the subtalar joint, which is inferior to the talus and superior to the calcaneus. So similarly, you can take those same two fingers you used to find the talus and just slide them a little bit further down until you reach the calcaneus in order to find that joint on the posterior side. From there, you can move anteriorly, or you can reset to the top of the talus and move down the front of the talus to find the mid-tarsal joint, which is where the talus and calcaneus start meeting the navicular and cuboid. So right here within the joint. There is also a tarsal-metatarsal joint, and that is the junction between the distal row of the tarsals, so right along here, and the proximal part of the metatarsals. So again, continuing with our theme here, To find that, you can just continue sliding your two fingers along the edge until you feel the distinct spot where the metatarsals begin. Continuing along that same trend, you can continue along the metatarsals until you reach where the phalanges start to find the metatarsal phalangeal joint. And then from there, you can continue on to find the interphalangeal joints where they break up into the distal and intermediate and proximal phalanges. Looking at some bones specifically, to find the first cuneiform, which is a pretty notable bone, you can start at your first metatarsal, slide your fingers up until you reach a bony projection. That is going to be the first cuneiform. From there, you can continue up a little further to the second largest medial aspect of the ankle, which is second largest after the medial malleolus. And that projection is going to be the edge of the navicular bone. And then obviously this is hard to, you can't show this on this model, but the medial and lateral malleolus will be along the edge of the ankle. You have both the medial malleolus on the edge of the tibia, projecting out into the medial ankle, and the lateral malleolus off of the fibula, projecting off into the lateral side of the ankle. And the last two for the ankle, we have your talus. Obviously, as we've been talking about a lot here, you can find that just by sliding down the tibia until you reach the talus and the calcaneus. Below that is the most proximal aspect of the plantar part of the foot. So you can also palpate that just by reaching down and touching your heel is the base of the calcaneus. So then we're going to move into ankle muscles. We're going to start with the gastrocnemius and the soleus, both which can be kind of done together. To do that, you're going to have your patient go up on their toes, and by doing this, their whole calf is going to be flexed, and that is going to be the gastrocnemius is the most superficial muscle there. But to find the soleus, you can have your patient continue standing on their toes, but then flex their knees, which makes your soleus pop out along the inferior border of the gastroc down here. Then in terms of your anterior leg, the only muscle we really touched on as being important for this movement is the tibialis anterior, which you can palpate just by placing your hand on your anterior lateral shin and having your patient go through dorsiflexion, and it will pop out and you can feel the muscle belly. Moving into the knee, we have a lot of parts of the knee we can palpate as well. We'll start with the easiest one being the patella. Obviously, that's just right here, your kneecap. You can feel it the best by doing some knee flexion and extension, and you'll feel the round sesamoid bone pop out. From there, you can find your medial and lateral condyles by moving both either medially or laterally along your knee, and you can find those condyles sticking out as the most prominent outcropping right there. From there, you can move up slightly superiorly and slightly more posteriorly to the medial and lateral epicondyles along the bone as well. Then resetting, going back to the patella, you can move down slightly to an empty space along the tibia, which is the tibial plateau before the tibia starts. Moving from that empty space, again, medially or laterally, you can find the tibial condyles along the edge of the top of the tibia. Again, just taking two fingers and moving to the outside. You can find the tibial tuberosity by, again, the easiest way to do that is to go back to the patella and then just go straight inferior until you find a projection on the anterior superior tibia. And that's going to be your tibial tuberosity. From there, you can move superiorly and slightly laterally to find a little bump called Gerdy's tubercle. And from Gerdy's tubercle, you can move farther laterally and then a little inferiorly back pretty close to where the tibial tuberosity is to find the fibular head, which is the main part of the fibula that we will be able to palpate. In terms of muscles, the knee is a little easier to palpate than other areas. We kind of group them together in terms of the hamstrings and quadriceps. Starting with the quadriceps, those are going to be your anterior thigh muscles. To palpate those, you're going to have your patient extend their knee, and by doing so, that will make three large muscle bellies pop out of their leg. Moving from lateral to medial, you'll have your vastus lateralis, then you'll have your rectus femoris in the middle, and then on the medial side, you'll have your vastus medialis. The other quadricep muscle is your vastus intermedius, which is not palpable due to it being deep to the rectus femoris. Then moving on to your hamstrings, similar technique, you're going to flex your knee though, and by doing this, moving from medial to lateral, you'll be able to feel the muscle bellies of the semimembranosus, semitendinosus, and biceps femoris as you move again medial to lateral, you'll be able to feel those muscle bellies. The only other main knee muscle we talked about in our motion was the popliteus, which again, due to its depth, is not palpable for us. All right, then moving into the hip in terms of bony projections that are palpable, the easiest place to start is just on the anterior superior iliac spine. It's a very large projection on your anterior hip. It's very noticeable. From there, you can follow it backwards in superior to be along your iliac crest, the top of your ilium. You can also go back to the ASIS and place your hands down both medially and inferior to it. There should be 3 fingers, and then your 4th finger, your pinky, should be on your anterior inferior iliac spine, another little bump on the front of your pelvis. Going back to find the greater trochanter, the easiest way to palpate this is to take your hand and put it on the top of your iliac crest and just let it flop down. By doing this, your fingers should come across a bump or a bony projection, which is the greater trochanter of your hip. Moving to your posterior hip, your posterior superior iliac spine can be found by tracing again that iliac crest all the way to the back to where there is a bony projection right around here. Then from there, to find your posterior inferior iliac spine, you can take 2 finger widths below the superior iliac spine, posterior, and that will take you to 2 more bumps, which are the posterior inferior iliac spine. In terms of the hip, there's only 2 real joints that are very palpable, those being your lumbosacral joint and your pubic symphysis. The lumbosacral joint can be found by continuing down your vertebrae until you reach your final vertebrae between it and the sacrum. Obviously, as the name implies, the joint is between the final lumbar vertebrae and the sacrum. And then the pubic symphysis on the front of your body, you just move your hand down your rectus abdominis muscle until you reach a bony block, which is where the top of the pubic symphysis starts. Then lastly, looking at palpation of the hip and core muscles, we'll start with the sartorius. So for the sartorius, you're going to have your patient in a seated position. They're going to lift their leg off the ground while dragging it along your ankle up your leg. And by doing that, it makes the sartorius pop along the inside of your thigh. You'll be able to feel it there, feel the muscle belly. Then looking at your gluteus maximus, this is probably one of the easiest muscles to palpate. It's just right here, superficially. You can feel it even better during a hip extension if you want to make it flex out. Looking at your gluteus medius and minimus, those are a little bit trickier due to the fact that they're deep to the gluteus maximus. But you can find them a little bit easier if you do thigh internal rotation, and then they are along the borders of the gluteus maximus along the edge right here. Moving on to the piriformis, another example where here you have the patient lie on the ground in a prone position, and then you can feel the piriformis in between the greater trochanter and the sacrum when they rotate their hips. So you have your patient lying on the ground here, and then with your hand here, you can feel the piriformis when they rotate their hip out like that. Looking next at the quadratus femoris, it's kind of similar, but if you can do this one standing, if you have your patient externally rotate their hip, you can feel the quadratus femoris when you are looking between your greater trochanter, which we found earlier, and between your ischial tuberosity, which is the 2 attachment points of it. And lastly, the other muscle we looked at, they were the gemellus, and they are pretty difficult to palpate due to them being deep. However, they are slightly superior to quadratus femoris, which you can sometimes feel just by moving up along the muscle belly there.
Okay, so for the common injuries that we might have, we do have the ACL sprain, which comes from incorrectly landing after a jump. And we have gone over this in class, and we learned that there are 3 different types of the sprain and 3 severities. We have grades 1, 2, and 3. Grade 1 is the fibers of the ligament are stretched, but however the ligament is not completely torn or even torn at all, so there is joint stability still left. It'll just feel a little wonky, a little hurt. We do have grade 2, though, which the fibers of the ligament are partially torn at this point, and there is some joint instability, so the joint will feel a little loose when you put weight on it. And then in grade 3, the fibers of the ligament are completely torn, and there is no more joint stability. And treatments are dependent upon the grade of the sprain, but overall they could be beneficial for any grade. And then for signs and symptoms, you might hear a loud pop or popping sensation within the knee. There will be severe pain and an inability to continue the activity. There will be rapid swelling. You might have a loss of range of motion depending on the severity of the sprain. And then there will be an overall feeling of instability when you're putting your weight on that joint. And then for treatments, we have the rest, ice, compress, and elevate, RICE method, as well as rehabilitative physical therapy. And then in grades 3 with higher severity of the sprain, you might have surgery to help with it. And then moving on, we have the snowboarder's ankle, which is a very specific injury that we see way more common within snowboarders than any other athletes. And this is because of the constant amount of dorsiflexion that we see within the ankle. And with this, the talus is locked in place during its dorsiflexion, and then its LPT section is compressed between the calcaneus and the fibula, and then when landing, this eventually will fracture the bone because of the compression between the two. And then we see this type of ankle sprain 15 times more common to 50 times more within snowboarders than any other ankle injury that they might have. And then for signs and symptoms of this, there might be pain and swelling within the ankle. There's going to be tenderness around the back of the ankle because it's affecting the talus. And then you'll have difficulty walking, and you might have an inability to bear weight. And then for treatments, we once again have the RICE method. And after you have this injury, you will have to have initial mobilization of the ankle joint for a minimum of 6 weeks. You may have to have surgery depending on the severity of the fracture, and then rehabilitative physical therapy as well, depending on the severity of the fracture. And then finally, we have our wrist fracture, which is perhaps the most common snowboarding injury. And this happens when you fall incorrectly on outstretched arms to maybe stunt the fall, but it will actually damage yourself. And there are different types of wrist fractures. However, the most common that we see within snowboarding is the distal radius fracture, as well as a fracture within the scaphoid bone. And then for signs and symptoms of this, we have pain and swelling. You might find it hard to move your hand or wrist. There could be slight deformation of the wrist because of the fracture. And then there could be a tingling or numbness at the tips of your fingers, depending on how severe it is. And then for treatments, you won't have the RICE method because it's elevated by itself and use it more commonly throughout the day. So you can get away with wearing a wrist splint or wearing a cast, and then in more severe fractures, you will have to have surgery for this injury.
All right, then our final section on this movement and resulting exercises, we want to talk about strengthening of the muscles that are involved. So again, we're going to start with the ankle, and as we talked on earlier, the main muscles involved with ankle movement here are the gastrocnemius, the soleus, and the tibialis anterior. So in terms of the gastroc and the soleus, the best way to build muscle strength here is to do a double leg calf raise. So you can either stand on the ground or on a stair. And then when you're on the balls of your feet, you're going to pick your heels up and push straight up until your body extends all the way to the top of your toes, and then come right back down. And then you just repeat this, and that strengthens your gastroc and your soleus. And then for your tibialis anterior, you're going to have your patient sit down and hold an elastic band around the bottom of their foot. We do not have one here, unfortunately, but pretend that's around the bottom of your foot. And then having the patient dorsiflex their foot strengthens your tibialis anterior there. Moving up to your knee, again, we talked about the muscles of the knee being in groups, both the quadriceps and the hamstrings. So for your quadriceps, your best option for strengthening is going to just be a squat. So you stand with your feet shoulders width apart and lower yourself down, sticking yourself as if you were to sit in a chair with your butt back and your hips back until your thighs are parallel to the ground, and then extending back up to your starting position. Repeating that will help strengthen those muscles. And then for your hamstrings, again, it's a resistance band exercise, which we don't have any resistance band with us, but you're going to have your patient lie flat on their stomach with a resistance band here around their ankle, and then attached to something solid back there, and then have them flex those hamstrings and extend them back out like that. And our final group of exercises to strengthen is through the hip, in which we're going to look at the glutes, sartorius, the gemmelluses, and the piriformises. Best way to do the first section of these is through fire hydrants, in which you will have your patient down on their hands and knees. Both your hands and your knees are shoulder width apart. They're then going to take one leg at a time and rotate it outward, maintaining your 90 degrees at your knee joint, but getting to about 45 degrees with your hip joint, like that. And then the final set of exercises we have are crossover step-ups. And for this, you're basically going to have your patient, they'll have a box here or something to step up onto, and they will take the outside leg, cross over the inside leg onto the box here, and then step up. Obviously they won't jump, but we're a little limited in our supplies. And then step down the other side and then do this on the opposite side as well. So that is our presentation on the snowboarding movement of a 360-degree jump. Thank you for your time and for everything this semester. Thanks.